Some other screening scales are the Hamilton Depression Rating Scale. This has 21 items. It's really great sensitivity and specificity, so it's going to tell you, you're going to rule out your false negatives and false positives. So it has really high positive predictive value for recognizing actual depression. So it has it's great for screening and case finding. But here's the downside. It is a clinician-rated rating scale. It's very time-consuming to administer, and it requires some training in order to be able to administer it. The next one is the Hospital Anxiety and Depression Scale, or the HADS-D. Again, this one's only 7 items, so the advantage is that it's rather brief. But remember, none of these scales were designed specifically for stroke, so a lot of them you have to modify the cut scores, so at what level you decide somebody might have depression and they need further referral. So you may have to modify the cut score on the HADS. The Beck Depression Inventory has been used in stroke, and this is a nice scale. It's 21 items. It has really high sensitivity. It also was designed to detect changes in symptoms. However, some research was done on this scale, and it turns out that 5 of those 21 items really don't work well in stroke. And so it has low clinical utility for screening and case finding within the stroke population, even though that's a very famous and commonly used scale in depression. A couple of other scales I want to just mention are the Montgomery-Åsberg Depression Rating Scale. This is 10 items. Again, this has the advantage of measuring changes in symptoms over time. This one also, though, is clinician rated, so it's time consuming even though it's 10 items. The cut scores for stroke are a little bit unclear, and the scale also requires training in order to be able to administer it. And then there's the Geriatric Depression Scale. This one is kind of nice because it's 15. The original one has 15 items. The sensitivity is not so great, but it's fairly specific. The advantage of this one is this is the only one that has the answer format is yes or no. The rest of them are all Likert scales. So like kind of how often have you had this symptom, from like very often to somewhat to sometimes, and they sort of run on 5-point Likert scales. So if you have somebody with some mild cognitive impairment or mild aphasia, and it's easier for them to give sort of one-word answers, this format works a little bit better. But you see high heterogeneity, so lots of bouncing around with the scores, and it's low positive for predictive value, so it's not perfect anyway. Okay, so I wanted to give some credit. I was very lucky. Meader and colleagues had put together a really nice paper looking at these screening tools for post-stroke major depression, and so I was able to use a lot of their stuff, so I wanted to acknowledge them. Okay, so what do I recommend? Where are we? So I am at the point in my research, if I were doing it clinically, I would use the PH2Q as a screen and follow up with the PHQ-9, just because that seems to be where a lot of the research is going. And I like it has high sensitivity and high specificity, with the advantage of being able to detect differences in symptoms over time. So it seems like a lot of folks are headed towards the PHQ-9 in stroke at this point. Okay. So when you think about, I mentioned a few times, when you think about screening a stroke survivor for depression, you want to make sure that you're using a tool that maybe has less of those somatic symptoms, or if they're coming up positive for a lot of those somatic symptoms, maybe rule out, is that just a side effect of the stroke, or is that really part of depression? Again, remember I mentioned that PHQ-9 assesses for suicidality, and so you have to have a plan in place to really understand what that means. And that question is worded kind of funny. It's have you had thoughts of harming yourself or others or something like that? And I would recommend that if you're going to use the PHQ-9 or any tool that assesses for suicidality, you have a suicide plan in place. And one of the things you first want to do is really screen, is this patient really suicidal, or are they just, is it that they've had those thoughts but they're not actually going to act on them? There's lots of levels for understanding suicide, and if somebody is truly suicidal, even if they say yes to that particular question on the PHQ-9. The Columbia Suicide Rating Scale is excellent for trying to understand further if the patient is actually suicidal. And what steps that you have to do with that. And so I would recommend that. They have a beautiful online training. It takes about a half an hour to go through the training. And I use this in my research because I do screen I do use the PHQ-9 in my research, so I do have a suicide plan in place, and I use this Columbia Suicide Rating Scale. It takes, so the PHQ-9 takes about, I'm going to get this wrong, Karen, how long does it take to administer? 4 minutes to administer. Maybe less if the person's quick, maybe a little more if they're slow. But then the suicide rating scale probably takes an additional 10, but it's not an enormous amount of time, and I'd rather really know, is this patient suicidal and do I have to do something about it, or is it that they've had these thoughts but they have no plan and they have no intention of ever acting on them. They just sometimes, they had a stroke and they wish they had woken up dead instead of having the stroke. Okay, so again, remember, keep in mind those response categories in the scales, and sometimes it may be better to use something like the GDS if you really have somebody who's having trouble with response categories, or one of those clinician-rated scales. That's why I talked to you about multiple scales. So if you're dealing, I'll get to aphasia in a minute, but so if you're dealing with cognitive impairment or aphasia, you maybe do better with one of those. The amount of time you have to screen a patient makes a difference. Again, that's why I love the PHQ-2. It's super quick. You can get that in less than a minute, those 2 questions, and then at least you know if you have to move on to further screening. And what is the goal of your work with the stroke patient? Is it just to screen, or is it to diagnose or to detect changes in symptomatology? May depend on which scale you use. Again, for diagnosis, though, the structured clinical interview is actually the gold standard for diagnosis, while the PHQ-9 has sort of recommendations for levels of depression. If you really want to know if somebody's depressed, they need a structured clinical interview. Okay, so I mentioned the aphasia and cognitive impairment, and then the other tricky thing is that post-stroke emotionalism. What does it mean when they're just pathologically crying? And that gets really confused with depression, and the family will tell you that they're depressed, and it makes assessment really tricky. So here's some recommendations, at least for aphasia. 1 in 3 stroke survivors have aphasia. This is the impaired language comprehension or expressive abilities. And there is no validated method for assessing depression in severe receptive or global aphasia. It's just really hard to communicate with these folks. And the more neurologically impaired, the more subjective your assessment is going to be. But there are a couple of scales in order to do that. There's the Aphasic Depression Rating Scale, which has a couple of items that are clinician administered. There's also the Stroke Aphasic Depression Questionnaire. Both of these are the Aphasia Depression Rating Scale is based on clinician observation, so it would be your observation of the patient. And the Stroke Aphasic Depression Questionnaire, you would have a conversation with the caregiver, whoever their family member is that's recognizing the symptoms. Other ways to assess it are things like visual analog scales, if they at least can understand but maybe can't speak. Other observer rating scales, things like the Montgomery-Åsberg rating scales, and talking to an informant. So actually just using the proxy and using one of the other validated tools. Okay, so cognitive impairment, you're a little bit in the same boat as with aphasia. The way we do assessment in cognitive impairment is by using informants or proxies. These are the folks who at least knew what they were like before and can tell you what the behavior is like since, although, again, that post-stroke emotionalism confuses caregivers tremendously. The visual analog scales can be helpful, especially when you're dealing with cognitive impairment. We use those even with Alzheimer's patients and non-stroke cognitively impaired folks. And then some of those observer rating scales, like the Montgomery-Åsberg Depression Rating Scale or the Hamilton Depression Rating Scale. One I didn't discuss with you but is commonly used in dementia is the Cornell Scale for Depression and Dementia. These can all be used in stroke when the stroke survivor has significant cognitive impairment. The downside is you have to just keep in the back of your mind is that these scales tend to overestimate depression. Okay, so unfortunately, I told you we have a whole bunch of hypotheses, but we really don't understand the etiology of post-stroke depression or fatigue, and I'll get to that in a minute. So it's difficult to devise interventions to target particular mechanisms. You would always want to start with treating any underlying physical condition. So if they have chronic pain, treat the chronic pain. That will reduce their depressive symptoms. So far, psychotherapy alone has not been shown to be effective at all in reducing post-stroke depression. So right now, the treatment of choice is antidepressant pharmacotherapy, and you would always want to start with a selective serotonin reuptake inhibitor, an SSRI. So treatment with an antidepressant after about 6 weeks is effective, but only in about half the cases. So it's the best we've got for right now, but it is not fully effective. Antidepressants are not successful for preventing depressive symptoms. So it's funny, the docs I've worked with through my research seem to fall into two camps. They want to put everybody on an antidepressant, or they are reluctant to put anybody on an antidepressant without further education to do so. But it doesn't really help to just stick everybody on an antidepressant because it doesn't prevent anything. And then you're putting people on medications, with fairly significant side effects that they don't need. You'd want to watch out for any serious adverse effects with antidepressants, such as seizures, falls, or delirium, especially. But the more common side effects, like sexual dysfunction or fatigue or weight loss, apathy, insomnia, those are all sort of normal SSRI side effects. So again, don't just throw everybody on them if they don't need them. Okay, so I want to move on to post-stroke fatigue. Fatigue is even more elusive than depression, although more common. And so fatigue is a subjective lack of physical or mental energy that's perceived to interfere with usual and desired activities. It's experienced by at least half of stroke survivors at some point during their recovery, and usually it lasts for years. It's associated with their inability to return to work, poor quality of life, and they actually say it's the most difficult sequelae of stroke that they have to adjust to, is this, they call it the invisible symptom of fatigue. It's also associated with anxiety, depression, functional impairment, and pre-stroke fatigue. So if they were fatigued to begin with, then they're often more likely to be fatigued. It occurs in the absence of depression, obstructive sleep apnea, and other medical conditions, and that's led to the concept of actually primary post-stroke fatigue. You would also want to rule out any of these things first, but it does happen in those cases. The core characteristics in stroke are the lack of energy to perform activities, abnormal need for long-lasting sleep, being easily tired by an activity, and abnormal need for naps or rest. It's unpredictable, the feelings of fatigue, without any explanation, so it may not be that they did something to tire themselves out. And they have increased stress sensitivity. And I hear the stroke survivors I work with fatigue talk about also this mental fatigue, like thinking makes me tired. Unfortunately, because it's multidimensional, it likely has multiple causes, and so we're all kinds of confused about what the etiology is. So the theories, to start out with, it was just like, well, they're fatigued because they have a hemiparetic gait and they're working so much harder to be able to walk, or they have all these other problems that they're having, and so they're malnourished and they're having other issues. So certainly that's still true. If they have those other issues, you want to address that. Another theory that's in the literature currently is that it's the attention deficit that results from damage to the reticular formation and related to structures that are involved in the subcortical attentional network. My theory, again, I'm working on this with fatigue and depression, is that it has something to do with the inflammation, and that alters mitochondrial functioning, resulting in inadequate cellular energy production. Okay, so there's no one best screening tool for fatigue, but I'm going to talk to you about the measures that are out there. So there's the multidimensional fatigue inventory. So these are tools that have been used in large trials of fatigue in stroke. This is a 20-item tool, and what I like about it is that it measures these multiple dimensions of fatigue. It has several subscales, and so you can sort of tease out which kind of fatigue your stroke survivor might be having. Is it general fatigue, physical fatigue, mental fatigue, or reduced motivation or reduced activity? The downside is that it's not validated in stroke patients. The other one is the PALMS fatigue. It has good internal consistency in stroke and high construct validity, but it has poor test-retest validity. NIH has recently come out with a whole bunch of measures that they want everybody to use because they're trying to make research more comparable. And so they're called the PROMISE measures, and they've got a 7-item or 8-item fatigue scale. Unfortunately, though, these were not validated in stroke. They were validated in cancer and other things. The fatigue severity scale was designed to detect changes over time, which is nice, and it's 7 items, and it has been validated in stroke, and this is the most commonly used one. The fatigue assessment scale is 10 items. It measures different facets of fatigue, which is nice, but and has the best test-retest reliability and high construct validity. But the downside is it has low internal consistency in stroke, probably because it has several subscales, and they were all evaluated as one. There's the vitality subscale of the SF-36. This actually is a proxy of fatigue. It measures vitality, which is sort of the opposite of fatigue, and so it has weaker constructability with fatigue. Okay, so for interventions, you just want to treat any of those underlying causes first. As I mentioned, treat the nutritional deficits, anemia, fluid and electrolyte imbalances, post-stroke depression, sleep disorders. Other than that, there are no evidence-based interventions for fatigue, but there's some studies going on looking at possibility of cognitive therapy and physical activity combinations or mindfulness-based stress reduction for mental fatigue. Okay, so these are my take-home points. Depression and fatigue are really common. You want to assess for depression. I'm recommending the PHQ-9. I didn't make a recommendation, but I'm recommending the fatigue assessment scale in stroke. There was one study who looked at a whole bunch of fatigue scales in stroke, and this is their recommendation. Everybody on the healthcare team is responsible for assessment of both fatigue and depression. And importantly, you need to take these symptoms seriously of depression and fatigue and treat any underlying causes. Treat the depression with an SSRI and refer to a mental health practitioner. Physical activity or reduction in expectations of what a stroke survivor can accomplish is good for fatigue. Acknowledge the symptoms and teach the family about them. And we need more research. So I'll have my work cut out for me. Thank you.